B, bradycardia, C, respiratory depression, and D, meiosis. Meiosis is contraction of the pupils. The cocaine is an stimulant of the nervous system and has adrenergic activity, so has sympathomimetic activity. So patients that are high in cocaine are going to have tachycardia, hypertension, dilation of the pupils. There is no respiratory depression associated with that. So you can rule out bradycardia. You can rule out respiratory depression because this is not a depressor. You can rule out meiosis because it produces mydriasis. So obviously the option that can be left is seizures. The overdose of cocaine can produce seizures, can produce hypertensive crisis, tachyarrhythmias, brain hemorrhage, and even death. So those are the manifestations possible in cocaine overdose. The next question that I have here: which intervention is correctly included in the care plan of a client with hypothyroidism? The options are increase fluid intake, keeping the room temperature cool, offering meals that are high in calories, and restricting dietary sodium. Patients with hypothyroidism have cold intolerance, so keeping the room cool or cold is not good. So we can rule out this. The patient with hypothyroidism have tendency to gain weight, so the meals should not be high in calories. The food of the client with hypothyroidism should be low in calories to avoid weight gain, should be low in saturated fats because they have tendency to suffer of high cholesterol, and should be high in fiber because they have a strong tendency to the constipation. So definitively option C is not, because it should be low in calories, not high in calories. Patients with hypothyroidism have tendency to suffer hyponatremia, low sodium. It is because the fluid retention that occurs in the mixed edema that can dilute the sodium. So for that reason, there is not indication of restriction of the sodium in the diet. So the diet should be normal in sodium because the tendency to the hyponatremia. So obviously we discard B, C, and D. The answer is A. Why increase fluid intake? Mainly because the constipation. Clients with hypothyroidism have a very severe constipation. Is a staple of the disease. And patients with constipation, a part of increasing the fiber of the diet, should increase the fluid intake. So the best answer of this question is A, as in apple. Next question. The nurse received order of administering insulin Lispro and Glargine at 9 p.m. How are those insulin administered? Lispro insulin is a rapid-acting insulin, Lipro and Aspart. It's clear. And Glargine is a slow-acting insulin, is the Lantus, and has as characteristic that cannot be mixed in the syringe with any other insulin. So the only option here that separates the insulins, okay, is option A. Okay. because there is no need of timing the Lispro 30 minutes before meals because it is contraindicated. Lispro, because it's a rapid-acting insulin, should be given at the moment immediately before eating, because waiting 30 minutes to eat could produce hypoglycemia. And cannot be combined in the same syringe. So the best option here is option A. Give at 9 p.m. at the same time both insulins, but in separate syringes, 2 shots, 2 syringes, 2 shots. Next question. Which of the following females client is at highest risk for breast cancer? 30-year-old active runner, 40-year-old with twins, 54-year-old with 21-year-old child, a mother who had breast cancer at 65, 55-year-old with 2 kids, and sister who had breast cancer at 35. We can rule out option A and option B. First, because are relatively younger than the last 2 clients. Usually breast cancer is more common after 50s. So it's not common before 50s. And there is nothing in option A, which is a runner, or option B, who has just twins, that increase their risk for breast cancer. So A and B can be discarded. C and D are very similar. You have similar age, more than 50. Both have children, and both have relatives in first degree with breast cancer. C had the mother, but the mother had her cancer at 65. The option D has her sister with breast cancer, but her sister had the breast cancer at 35. It is said that when there is a relative in first degree, I mean mother, sibling, sister, or children with breast cancer, the cancer of the individual, the risk of for cancer, of breast cancer of individual is increased. But the younger the relative, the higher the risk, because it translates that is an important genetic influence that produces the tendency to develop breast cancer at early age. So in this question, of course, the one that has the relative with the cancer at the youngest age is option D as in diamond. What should the nurse include in the care plan after cardiac catheterization via right femoral artery? Increase fluids, cough and deep breathing exercises, early ambulation, monitor radial pulses. This patient is having the femoral artery, right femoral artery, catheterized. So has locally in the groin risk for bleeding and risk for obstruction. This client received iodine as an IV contrast to be possible to see the arteries, and receive, of course, X-rays. After the procedure, the patient needs to be at rest with the leg straight without flexing the hip for several hours. So early ambulation is ruled out, is discarded. The radial pulses are not related with the femoral artery. So option D should be ruled out. Nevertheless, you need to know that some clients have catheterization through the radial artery instead of the femoral artery. But here in this question, this is not the case. The question says that the catheterization was in the femoral artery. That has nothing to do with the radial pulses. So the options are going to be between A and B. Cough and deep breathing exercises are recommended in patients that have general anesthesia, are bed bound, have thoracic or abdominal surgery. This is not the case of this client. It's a client that after the few hours of rest to prevent bleeding in the femoral, in the groin area, is going to ambulate. So it has low risk of developing pneumonia. So usually there is no need of teaching those exercises in cardiac catheterization. Are important in a patient that had general anesthesia, that had chest or abdomen surgery, but not in cardiac catheterization. Apart of that, coughing, having a puncture in the femoral artery, could dislodge the occlusive system that they use to close the little perforation that they make in the femoral artery. And it is possible that cough could be contraindicated in those patients. So between increased fluid that has no contraindication is okay. And cough and deep breathing exercises, I favor, if I were in my Nclex and I have this question, I'd favor option A, because fluids are important to increase in clients who receive iodine contrasts. The iodine contrast, radiological contrast, are nephrotoxic. And it's important to accelerate and reinforce the excretion of this nephrotoxic substance as soon as possible, forcing diuresis with increment fluid. So it's a routine to enforce the fluid intake and even IV fluids in patients that receive iodine contrast. So it seems that the best option here is A. If you have any doubt, want any clarification, please ask me, because we are so few of you, and some of you don't like to speak. That's why I'm not asking you to answer. Next question say, with finding after cardiac catheterization, so something similar to what we mentioned here, requires follow-up by the nurse. Remember when they use this term, this idiom, follow-up, means that something is not good, something is bringing problem, brings concern, and need more investigation and eventually intervention. So after catheterization, the patient has symmetrically decreased pedal pulses, pain in femoral area, a lump in the femoral area, urinary output 60 milliliters per hour. So using the most useful strategy that we recommend to use, the urinary output is normal, so it doesn't need follow-up. So we can rule out D, as in diamond. Pain in the femoral area is expected. They make a cut, and then with local anesthesia is true, but the numb is going to disappear soon after the catheterization. And they pierce the femoral artery with a catheter, so it produces pain. Pain is expected, so can be ruled out. So should be between A and C. In relation with A, it is a trap. This is a trap because we are supposed to know that usually patients that go to cardiac catheterizations are patients with problems in the coronary arteries. And the people that have problems in the coronary arteries are not young people, usually are older people, and are people that suffer of high cholesterol, diabetes, they are smokers or active smokers, hypertension, risk factors that added to the age produce this process of atherosclerosis, or formation of plaques or fats inside the arteries, that is happening not only in the coronary arteries, but in the brain arteries and in the lower extremities arteries. So it is expected that a person going to cardiac catheterization with this characteristic, old and with risk factor for atherosclerosis, it is expected that the pulses in the feet are going to be decreased, because there is also atherosclerotic disease in the arteries of the lower extremities. But these are reduction in the amplitude of the pulses, the pedal pulses, should be symmetrical, because the condition is chronic and affects the same both lower extremities. If the problem would be acute, not chronic, as a consequence consequence of a thrombosis induced by the manipulation of the artery, then the pulses that would be decreased or absent would be only in the side of the catheterization. Yeah. So if both legs have decreased pedal pulses, it is expected in this kind of client, because it's symmetrical. So the best option there is the lump. What is a lump? Is an elevation, is like a tumor in the groin area. So what could be this lump? Well, probably it is a hematoma. What is a hematoma? It's a collection of blood. So what means that the collection of blood is building up under the skin of the site of the catheterization, the entrance of the catheter, that, you know, the artery is bleeding. And this is one of the complications that we need to monitor. So the concerning finding here is the finding of a lump in the femoral area in the site of the catheterization. Next question. How does pseudoephedrine work in nasal congestion and sinusitis? Pseudoephedrine is a very common sympathomimetic medication that is present in over-the-counter, free to acquire, not free, without prescription acquisition medication that are used for nasal congestion, common cold, etc. Pseudoephedrine and ephedrines are similar to the epinephrine. So they work producing vasoconstriction, the same as epinephrine. So the veins and blood vessels that are in the turbinates of the nose in people that have nasal congestion are going to experience vasoconstriction when topically nasal inhalations, okay, nasal sprays of the pseudoephedrine is used, like the Afrin, or even in swallowed medication. So the mechanism of action is vasoconstriction. For that reason, the pseudoephedrine is contraindicated in patients that have cardiovascular problems like coronary artery disease, or hypertension, or cardiac dysrhythmias. The pseudoephedrine has nothing to do with antibacterial or antibiotic activity, and is not an antihistamine, is not an anti-allergic medication. It is true that the pseudoephedrine elevates the blood pressure, but this is not the mechanism through which the pseudoephedrine improves the nasal congestion. What improves the nasal congestion is the vasoconstriction of the mucosa and the turbinates, opening the passage of the air. Next question says, client's potassium is 7 milliequivalent per deciliter, which is high because, potassium, the maximum should be 5. Which prescription should the nurse administer first? So doctors make 4 prescriptions. 4, are there in the chart. So which prescription should be administered first? We have an order, the calcium gluconate intravenous, sodium polyestyrene enema, spironolactone oral, and dextrose 10% intravenous. One of the medications mentioned here is contraindicated in hypercalcemia. Spironolactone cannot be used in patients with hypercalcemia because spironolactone is a potassium-sparing diuretic that elevates potassium. So C is immediately ruled out. Dextrose is used in the treatment of hyperkalemia or high potassium, but together with insulin, because in reality is the insulin, the intravenous regular insulin, the one that can lower the concentration of potassium in the blood through a mechanism of shifting or displacing the intravascular, in the blood, potassium into inside the cells where the potassium is not harmful, is not bringing problem. But here they are mentioning only the dextrose. They don't mention the insulin, which is the acting component. So this is not, it is wrong. Why dextrose is given with the insulin? Because if we give insulin to a person who is not diabetic, is a person who has high potassium, no diabetes. If we give insulin to a person that is not diabetic, then it's going to have hypoglycemia. So for that reason, we give the insulin together with dextrose to prevent the hypoglycemia. But the medication that is going to lower the potassium is the insulin, not the dextrose. The dextrose is just to prevent a secondary effect, an adverse effect of giving insulin. That could be the hypoglycemia. So C and D are discarded. So now we are left with calcium gluconate IV and sodium polyestyrene enema. Sodium polyestyrene, brand name KX-alate, is a cation exchange resin. It's a substance that is not absorbed or passed to the circulation. It's a substance that is given either orally or in enema. In enema is faster, it's sooner in its action. The type of enema is a retention enema. So after administration, the patient should hold the medication for at least 1 hour. After that, the patient go to the bathroom, and in this resin that is in the intestine is an important amount of the potassium that was in excess in the blood, because this resin is like a sponge that can suck potassium from the blood in exchange with sodium. So the mechanism of action of this sodium polystyrene is sucking potassium from the blood and moving the potassium from the blood into the intestinal lumen, where it's going to be evacuated, it's going to be eliminated through a bowel movement. Nevertheless, this medication is slow in its action. It's important, it's a very important medication, always given, because it's the one that is extracting the excess of potassium from the body. But meanwhile, this medication works, something more rapid, something sooner must be done to prevent the patient dying from the hyperkalemia. The rapid long-acting medication that can prevent the high potassium toxicity are the calcium gluconate intravenous, which, because it's intravenous, is very rapidly acting, and the insulin. Of course, insulin with dextrose, but insulin is not mentioned here. So the best option for this question, the best answer for this question is calcium gluconate IV. Calcium gluconate antagonizes or stabilizes the cell membrane of the cardiac cells, preventing the development of the cardiac dysrhythmias that produce the hyperkalemia. So this is the best option for this question. The sodium polystyrene is not the best option because it's not the first to be administered, because it's very slow in its action, and is not rapid enough as to stabilize the client. First is giving calcium gluconate and insulin to stabilize the clients, and then the sodium polystyrene to clean the client from potassium. But if they are asking what is administered first, you need to go to the rapid medications, calcium gluconate and insulin. Client needs blood transfusion and is O positive. Which blood can receive? Select that apply. Patients that are O only can receive O. But because the patient is Rh positive, can receive O positive or O negative. So can receive A and can receive E. Nothing else. The nurse is going to administer nitroglycerin ointment. Ointment is like a paste, that comes in a tube dispenser that is like a toothpaste tube. This is nitroglycerin ointment. If for topical skin application. And then they are asking which of the following is correct. Applies to a non-chafed area and tape down the ends. Wash area with soap and water before applying. Place ointment in the same place where it was done in the previous dose. Wearing gloves, spread out the ointment to around 4 inches on the area of application. You learn that the most commonly form of prescribed ointment that is a very economic of nitroglycerin, and is the one that usually is approved by the Medicare, comes in a tube, but this tube brings a pack of papers, okay, sheets, small sheets, papers, with this shape. And then the doctor will prescribe 1 inch, half an inch, etc. And then if the doctor prescribes 1 inch, you are going to spread 1 inch of the ointment in the paper. And then you go to the client and apply body that has no hairs. Okay, this part is going toward the skin, of course. And then, of course, to prevent that from falling, you are going to apply tapes to make it stay there. It's not good shaving the area, because then the absorption is accelerated. There is no need of washing the skin before applying topical medication, unless the skin is greasy, sweaty, or dirty. So there is no need of washing. There is no necessity of washing. There is no need of that. The place of application should be rotated, because if you administer the medication always in the same place on the skin, it is going to produce irritation, especially the tape that you are going to use. And you don't spread out the ointment. Just you apply the ointment here, and then you stick the paper in the hairless skin of the client. So the best option there is option A, apply to a non-chafe area. It's important that do not chafe, and tape down the ends, as I explained, that is done. So this is the technique of applying nitroglycerin ointment, which is very common, especially in long-term facilities. A positive direct fluorescent treponema antibody absorption test confirms which condition: renal infection, syphilis, lupus, urethritis. The treponema pallidum is the bacteria that produces syphilis. So the fluorescent treponema antibody absorption test is the test that confirms that the person has syphilis. Syphilis is screened systematically in all pregnant women, in all people that are going to have, admission to a hospital, surgery, etc. People that have previous STDs is screened with test called the BDDRL, or the rapid protein reagent. Okay, rapid protein reagent. Yeah, RPR or BDRL. If any of those tests comes out positive, need to be verified, the positivity, with this confirmatory test. It's the same as HIV that required to test. The same happens with this. Which nurse intervention is correct routine when providing post-mortem care? So it's important to know that what we can do with a patient who died. Send the course for autopsy, allow family to join you in the post-mortem care, dispose of clients belonging in biohazard bins, contact the hospital chaplain for religious services. When you have a question like this, don't assume that the person has a specific religion, because it's not mentioned in the question. So you don't know if the patient is religious. You don't know if the family is really religious, and you don't know which religion is the client, because it's not mentioned in the question. So this is frequently present in similar scenario, and it's a distractor. So it is not the most important, because you don't know if the patient or the family is requested or are requesting, okay, religious services. The client's belongings doesn't need to go necessarily to biohazard, because the client clothing, for example, or jewelry, or I don't know, wallet, are not necessarily biohazards. So the client's belongings are collected and given to the family with documentation that were given to the family. So there is no need of disposing the client's belongings in biohazard bins. So you can rule out this. Not all the patients go for autopsy. In reality, the minority of clients who die in hospitals, nursing homes, etc., go to autopsy. The minority. So you don't send systematically all clients for autopsy. And the question is in general, post-mortem care. But what has no discussion, has no objection, is that if the family wants, you allow them to participate in the rituals and the routine of preparing the cadaver. Even some religions like the Muslims, the Buddhists, and the Jewish, they demand participating in the preparation of the cadaver because they have specific requirements. Usually it's to clean the cadaver and to dress the cadaver and to make it presentable. So obviously the best option here is allow the family to join in the post-mortem care. Next, the nurse is providing care for a client 1 hour post electroconvulsive therapy, electroshock. It is used in patients, especially bipolars, with bipolar depression, severe depression that doesn't improve with medication. What client statement requires the nurse intervention? So the patient says something that is wrong because the nurse must intervene. There are 4 statements. I cannot remember anything from this morning. B, second round of electroshock is in about 12 hours. C, I will not be attending group activities today because I'm very tired. D, I can expect having a headache after this procedure. So going again to rule out, headache is common after receiving an electroshock and having a seizure. So D is totally expected. A person who was sedated, the patient was totally sedated, they were put to sleep in the day and received a electroshock and had a seizure, is expected to be very tired, very drowsy, very uncomfortable. And of course, the group activities are not the best option that day for the client. So missing that day, the group activities is not an issue. It's expected. So now we need to deal with A and B. Not remembering, having amnesia for the period immediately before and after the procedure is expected because this procedure produces amnesia. The amnesia is transient and has, well prognosis. So you need to be reassuring to the client that it's something transient. But what is not correct is having 2 sessions of electroshocks in one day. Usually it's only one electroshock given to the client. So having a second round in 12 hours is unacceptable, it's not healthy. So it is totally wrong. So this is the answer definitively of this question. A diabetic client presents to the ED with acute alcohol intoxication, confusion, agitation, systolic hypertension, and tachycardia. Which nursing intervention is the most important at this moment? A, assess for other signs of alcohol withdrawal. B, administer IV thiamine as per protocol. C, assess capillary blood glucose. D, administer a benzodiazepine as per protocol. Notice that this client is diabetic. A part of diabetic is intoxicated with alcohol. Notice that the patient has altered mental status because has confusion, has agitation, is misbehaving, has tachycardia and hypertension, which are manifestation of fight or flight. It has activation of the sympathetic nervous system. There is
Who says, sorry, Professor, continue.
you say A.
I say C as in cat.
As yes in cat, yes, absolutely.
Because it's drinking and it will create hypoglycemia.
Exactly.
Like diabetes.
Which is the priority
Correct.
over alcohol withdrawal. The patient with hypoglycemia has priority over alcohol withdrawal. The alcohol withdrawal is something that develops along hours, even days. It's serious, can be mortal, but it's something that gives time. But the hypoglycemia should be treated as soon as possible, because the hypoglycemia, if it is severe, produce brain damage. That's why it could be producing confusion, etc. So I agree with you that hypoglycemia is the first to rule out. So obviously the first that you need to do is to find out what is having the client, what is the problem with the client, why the client is confused, agitated, etc. So assessment is needed. But there are two assessments, and the two are possible, and the two are necessary. But you need to choose first the most important, the most immediate. You have assessment for alcohol withdrawal, which is a possibility, and the other is assessment for hypoglycemia, which is the other possibility. Of both, which one has priority? The hypoglycemia. The hypoglycemia. Absolutely. If the patient has alcohol withdrawal, then benzodiazepine will be given. If what the patient has is alcohol withdrawal. If the patient has hypoglycemia, dextrose is given, depending. Okay. If the patient has both, then first you give dextrose, and then you start giving the benzodiazepine to prevent the evolution of the alcohol withdrawal in the seizure. Remember that in Nclex, when the patient needs a medication, you don't need to call the doctor. It is accepted and assumed that if the patient needs the medication, has been already prescribed by the doctor. Don't take decisions or don't limit your answers thinking that you need to call the doctor. When the patient needs the benzodiazepine, like Ativan, lorazepam, is because it's already ordered, it's already indicated. Okay, those are usually standard orders in the protocols. Okay, very well. Next question. A client with syndrome of inappropriate antidiuretic hormone, or SIADH. What the nurse expect to find? Zero that apply. So we need to say is true or is false. First, a refreshment. What is SIADH? Too much ADH. More frequently related with lung cancer, but can have many other etiologies. If the patient has too much ADH, the patient will have a reduction of the expected or normal urinary output, because this hormone is called antidiuretic hormone. If you have too much antidiuretic, do not pee hormone, then the peeing, the urinary output will be decreased. But then the water that should be eliminated in the urination is going to be retained in the body. So the patient will develop too much water in the body, will gain weight, will have edema, will have water in the lungs, with all the consequences. But the most important is because this water dilutes the sodium. Dilution means that if you have a solution which is normal and you add water in excess, then it's going to be diluted. It's more watery. So the dilution of the blood will produce a dilutional hyponatremia, which produces brain edema. This is the classical symptom of SIADH. So based on this refreshment, the options are decreased serum osmolarity. The osmolarity is the measurement of the concentration of the serum. If, as I said, the patient has a watery serum, blood, of course it is true. This is the opposite. High serum osmolarity, so automatically we rule out this. High urine specific gravity.
Yes.
Yes, precisely because the patient is not eliminating water in the urine is going to be concentrated. Specific gravity is the way of measuring the concentration of the urine. Low sodium in blood.
Yes.
Because the patient retains water and is having a watery blood, then the sodium is diluted and then drops below normal. Increase urinary output?
No.
No, because precisely we said that if you have too much do not pee hormone, then you don't pee. So the urinary output will be decreased. So it's an easy one. Usually the scenarios that apply are easy questions. Parents brings child to the ER and the client has a suspected hemolytic uremic syndrome. So it's a question apparently about hemolytic uremic syndrome. Hemolytic uremic syndrome is something very serious. It's more frequent in children, but can occur at any age. But it's much more common in children. The name says everything. The person has hemolysis and uremia. Urea or blood urea nitrogen bond, yeah, is a substance product of the metabolism of the proteins that builds up, accumulate when there is renal failure. Those patients develop acute renal failure. So they have hemolysis and acute renal failure. But a part of these two characteristics, they will develop several other complications that we don't need to know. But what we need to know that usually this is very serious. It can be lethal, okay? Can be lethal. Can be lethal. The hemolytic uremic syndrome usually occurs in healthy children, which is sad. Make it very sad. At least I think that is logic because it's unexpected. And is produced by a strain, a very aggressive strain of E. coli, Escherichia coli. Okay? So there are many strains of E. coli. Some are benign and are normal flora. Some are very aggressive, are not normal flora. These very aggressive E. coli live mainly in the intestine of animals like cows, horses, goats, etc. So this is a serious condition, but which is triggered through immunological activation by an infection with E. coli, an aggressive strain of E. coli. So this is the most important to know. So the question said that there is a child with a hemolytic uremic syndrome. And the question says which question is appropriate for the nurse to ask. In this case, the intention of the question is to find out the origin of this condition. So the options are, does your child have any food allergies? So food allergies had nothing to do with this. because this is not food allergy. Peanuts allergy, shrimp allergies are important for that, no? And produce urticaria, angioedema, anaphylaxis. But this is not anaphylaxis. This is not angioedema. This is not urticaria. This is hemolytic uremic syndrome. So we can rule out that. Then what has your child eaten in the past 72 hours?
Oh.
So the E. coli is a bacteria that is fecal oral. So the E. coli live in the intestine of people or animals. Yes, and is acquired orally. So it's fecal oral. So how a person can consume a bacteria that is in feces? Well, because food and water can be contaminated with feces. If you think that is not frequent, you are wrong. It's very frequent. It's very frequent. For example, this is the most common way of transmission of hepatitis A. And many of the diarrheas of enteric diseases. Fruits, lettuce, vegetables, food that are consumed raw, not cooked, can be contaminated with particles of feces. And also water, ice, etc. In America, it is rare because America is a very strict country about this. So it is a possibility. The other question is, has your child traveled out of the country recently? It is an important question that apply precisely to situation diseases, infectious diseases especially, that are more common offshore than in America. And did your child have sore throat and fever last week? No, because it isn't a strep throat, and the strep throat has nothing to do with the E. coli and the hemolytic uremic syndrome. It would be important for other diseases, but not for this. So now, probably, if you have this question in your English or similar question, you were left, I think, if you work logically and with the basic knowledge, we'll be left trying to decide between the two questions. So a part of learning about hemolytic uremic syndrome, if you didn't know about this condition, is thinking that what is more important to ask an American child, okay, you know, any child, any neighbor's child that arrived to the ER with the uremic hemolytic syndrome. So you need to decide between these two. Anybody have a pick?
I would say C because normally, like out of the country, like in our country, it's less, infection control, or it can happen more infection things than here, I think.
I agree with you. The two options possible are B or C, but if I were in my English, I will thinking in C, because the most probable that the child or the parents, the child would be telling me, well, these children ate McDonald's and ate Pizza Hut and ate Cheetos at home, because it's what people eat here in this country. But those foods that are not very healthy at all, but they are not infectious foods. They can kill you through a myocardial infarction or maybe cancer, but not through infections. So in America, the food produces cancer and myocardial infarction, but not infectious. But when you travel offshore, it's a very common that food is contaminated. In the end, the fecal oral diseases like hepatitis A, the diarrheas like Shigella, Salmonella, E. coli, etc., are very common. So if you ever traveled out of America and go especially to the Caribbean or Central American, South American countries, it's probable that you get a diarrhea. It's called the traveler diarrhea, because people that live in a very clean country, like usually is Europe, West Europe or America, North America, lose defenses against those bacteria that are so abundant in the food and the beverages in those countries. And then people usually get diarrhea, the traveler diarrhea. So I think that the most pertinent question in this case would be C as in cat, for the same reason that the student mentioned. This is also my opinion. But this is a way of getting, an educated guess in this kind of question that could be in your English and that maybe you don't know. And then you can find, okay, with logic, the answers. Next question. Client has a crisis of acute asthma. Which of the following medication, acute asthma, attack of asthma, which of the following medication do you administer at this moment? Oral steroid, humidified oxygen, inhaled salmeterol, oral chlordiazepoxide.
C.
Okay, it's important to remember. It's important to remember that the bronchodilator beta-2 agonist that is used in acute asthma is the albuterol. Because it's a rapid-acting beta-2 agonist and bronchodilator. The salmeterol and the formoterol are also beta-2 agonists, but long-acting beta-2 agonist that takes time in start working and have been associated with increased mortality in asthma and are not recommended in asthma. The one that you need to use and defend in an acute asthma attack is the albuterol, not any other. The only thing that can be combined with albuterol is the ipratropium. Ipratropium is a medication that can be combined with albuterol, not alone, but combined. Ipratropium, atropine, okay? Because it's going to potentiate the albuterol through a different mechanism of action. It is anticholinergic, and this is beta-2 agonist. But albuterol is the rescue medication, is the life-saving medication in the acute asthma attack. So it is a trap. This salmeterol is a trap. It's a trap. Patient with acute asthma attack receive basically albuterol, can be combined with ipratropium, IV fluids, and oxygen, nothing else. The glucocorticoids have no role in the acute asthma attack. The glucocorticoids have a role because they are a slow-acting medication in the prevention, okay, of the asthma attack, decreases inflammation. The best are not oral, the best are inhaled. But this is something that is not used. Inhaled glucocorticoids are not used in the acute asthma attack. Inhaled glucocorticoids are used every day to prevent the asthma attack. When a patient is using glucocorticoids before inhaling the glucocorticoid, must inhale a bronchodilator, like albuterol. Because the rationale for that, the reason for doing that, is because the glucocorticoids, when they are inhaled, produce bronchoconstriction, narrowing of the bronchi. If you use first the bronchodilator and second the inhaled glucocorticoid, this adverse effect of the inhalation of glucocorticoid is bypassed, is avoided. But because this predisposition to produce bronchoconstriction and the slow mechanism of action, the prolonged time that takes to work, that's the reason for which any glucocorticoid is part of the treatment of an acute asthma attack. The acute asthma attack is treated with albuterol, ipratropium, IV fluid, and oxygen. If the patient doesn't improve with that, then the patient is going to have other bronchodilators that are toxic, like the theophylline. And if it still doesn't improve, the patient needs assisted ventilation, intubation, sedations, and a ventilator. Okay. The role of the steroid is long-term, is not acute. Okay. So neither steroids nor salmeterol and less chlordiazepoxide. There is contraindication of giving sedative to patients with asthma attack, because precisely you want the patient very alert, very aware, very awakened to fight for air. If they are sedated and they start hypoventilating, they can quickly develop complication. So the right answer of this is oxygen. The nurse is going to administer the ordered dose of...
Answer, Professor? What is the answer?
B.
All right, thank you.
Attention. The nurse is going to administer ordered dose of nifedipine. What should the nurse evaluate before administering the drug? Heart rate, potassium level, blood pressure, AST, and ALT. Okay, sometimes the questions in the English are very easy. Okay. The only option here is blood pressure, because nifedipine has no influence in heart rate and is not hepatotoxic and doesn't affect the potassium. So blood pressure is the only possible answer there. So it's an easy question. The nurse explains to the student that acetaminophen toxicity has the following characteristic. Select of that apply. So what of these findings is compatible with Tylenol toxicity? AST 80, ALT 340. Those are both are elevated, so those are findings. Because they don't elevate immediately. They elevate after, after 1, 2, 3 days of the ingestion. But they elevate. They start elevating, can elevate much more than that. Prolongation of PT and INR with bleeding, yes. When the patient develops fulminant hepatic necrosis, because the toxicity of acetaminophen, when it is not treated and is left to advance, the patient will have acute hepatic insufficiency, and prolongation of the INR and bleeding is one of the manifestations of hepatic insufficiency. Liver diseases produce bleeding. because the coagulation factors, the substances that avoid bleeding, the substances that coagulate, are produced in the liver. When the liver is sick, like in cirrhosis or this fulminant, catastrophic, okay, toxic hepatitis that happens in overdoses of acetaminophen, okay, the patient presents bleeding because coagulopathy, because prolongation of the INR. Is treated with N-acetylcysteine? Yes, this is the treatment of the acetaminophen intoxication. After decontamination, then N-acetylcysteine is the treatment to counter the toxicity of acetaminophen. Symptoms of toxicity, mainly the hepatic failure, are observed 3 to 4 hours after intoxication? No. Usually after 24 hours is when it start presenting the symptoms of liver insufficiency. Toxic drug limit is 6 grams? No. In adults, the toxic dose limit is 4 grams. Above 4 grams, then is when can appear the toxicity. An infant who has been in foster care since birth requires a blood transfusion. It's a baby that is in foster care, has foster parents, and requires a blood transfusion. For blood transfusion, consent is necessary from the parents or caregivers. Who is authorized to give written informed consent for the procedure? The foster mother, the social worker who managed the case, the hospital ethics committee, the court who knows about the foster case. The answer to this question is A as in apple, is the foster mother. Foster mother doesn't mean adoption. Okay? It's a transient role. It's not a permanent role. But meanwhile, okay, the child is in foster care. The foster parent, then the foster parent acquires the right to give consent for the child. So it's a legal detail, which is good to know, because we request the signature of the consent, and we need to know to whom you need to ask to sign the consent. A 5-month-old infant is brought to the clinic by the mother, who reports that he has nasal congestion, fever, and difficulty breathing. The nurse should first, what? Ask for history of allergies, perform a respiratory assessment, notifies the physician, takes vital signs, including temperature. In this question, they are, I think, exploring if you understand what is a focus assessment. When people have acute problems, serious problems of health, you need to make an assessment that is focused, is centered, is limited to the problem that could be life threatening to the client. In all this scenario, the concerning is this word, difficulty breathing, because fever and nasal congestions are not concerning. Fever doesn't kill, nasal congestion doesn't kill, but difficulty breathing can kill, depending on the severity. So here in the question, the issue is difficulty breathing. So you need to decide if it is difficulty breathing is serious and requires a rapid action, or is not so serious, is mild and can wait. So obviously an assessment is necessary. History of allergies are not the assessment that is going to bring the best information for a difficulty of breath in a client at this age with fever. So we can rule out that. A assessment of the respiration is pertinent. Notification of the physician need to wait for our assessment. So you can rule out notify the physician. It is posterior because you are looking for what you do first. And the others are vital signs. So respiratory rate, blood pressure, heart rate, temperature, okay? So having a client with difficulty breathing, which focus assessment is going to give more information to take decisions? The respiratory assessment or the vital signs is the question. If I were in my Nclex, I know that a focus assessment in respiratory system would probably give me more information than the temperature that we already know that has fever or any other vital sign parameter. So in this case, probably the answer is B. The nurse is hanging the bag of blood for a transfusion. What is the correct way of administering the transfusion after the tubing is primed? So bag of normal saline and blood with independent tubing. The normal saline clamp, the blood open. Bag of normal salines and blood connected with white tubing, blood and normal saline opened. Bag of normal salines and blood with independent tubing, both left open. Bags of normal salines and blood connected with white tubing with normal saline clamped and blood opened. It's an easy question. So you need to know that when you have somebody with a transfusion and you hand the transfusion, because this patient already has an IV and a tubing, but this tubing need to have a white connection and in lines a filter. So here is necessary a filter. So this is the special tubing necessary for transfusion. In one arm of the white tubing, you need to have a bag of normal saline. And in the other arm, you need to have the bag of blood. The same height, it doesn't need to be different height. So when the transfusion starts, the bag of the normal saline should be clamped, and the bag of the blood should be open. So what is going to happen here is that blood will descend through the tubing to the client with the normal saline clamp and the blood open. So the best option here is this one. A nurse is caring for a client who had a vaginal delivery 4 weeks ago. 4 weeks. The client has saturated a perineal pad in 4 hours ago. The client has saturated the perineal pad in 20 minutes. So it's bleeding. Because a perineal pad should be saturated in 1 hour, not in 20 minutes. So it's bleeding. During assessment, the nurse notices that the client has a baggy uterus which is deviated to the right. So which intervention should be performed first? When the uterus is not well contracted and is bleeding, is baggy, and is deviated at one side of the abdomen, is because the bladder is distended. And the distension of the urinary bladder prevents the uterus from contracting. So massaging the uterus will not produce contraction of the uterus, because meanwhile the bladder is not emptied, the uterus won't be able to contract, no matter how much massage or how much Pitocin, okay, how much Pitocin you administer. So the first to do, because they are asking you what do you do first, is to empty the bladder. So the answer to this question is A, which is a classical question. Male client with type 2 diabetes mellitus, well controlled with metformin. 6 hours ago, the client went to a cardiac catheterism with iodine contrast. Now the client is telling the nurse that his metformin dose is due. Which of the following intervention is the appropriate to be carried out by the nurse? Reinitiate metformin with a snack. Determine capillary blood sugar before giving metformin. Continue administering fluid for 48 hours more. Administer metformin with water. A person who was taking metformin and go to iodine contrast cannot restart the metformin until 2 days later. 2 days later. So and this patient is only 6 hours of the catheterism. So any of the options that mention metformin is correct. So the only possible option here is C. Administer fluids for 2 days more without metformin. Okay, so is the only possible answer of this question. Client is going to a cardiac catheterism to determine extension of the coronary compromise. Which lab finding requires follow-up before the procedure? So cardiac catheterization requires incision in the femoral artery, so the coagulation need to be okay. And it is going to require the administration of iodine, so the patient cannot be allergic to the iodine, cannot be taking metformin, and cannot have renal disease. So based in this theory, we have an A1C elevated, the patient is a diabetic, not well controlled. Creatinine 1.8, which is high, the patient has renal failure. Positive hepatitis B antibody, the patient is a carrier of hepatitis B, so standard precaution with this client. The hemoglobin is 10, so has an anemia. And then you need to know that which of these four contraindicate absolutely the cardiac catheterism, because the high blood sugar in the last 3 months, the fact that it's a carrier of hepatitis B or has a moderate anemia are not contraindication for cardiac catheterization, but the renal failure is a contraindication because the patient cannot receive iodine. So the answer of this question is the creatinine. Which step should the nurse take first when administering a liquid medication to an infant? First, what step needs to be done first? Hold the infant securely and raise the infant head to about 45 degrees angle or higher to prevent aspiration. Place the dropper or the syringe at the corner of the infant mouth and let the drug run into the pocket between cheek and gum. Identify the infant by checking the armband and asking the name to the parent. Verify the physician's order and the available medication. So they are asking you what you do first, what you need to do first in these 4 options. Any idea?
A, as in apple?
Okay, before administering before administering, okay, any medication to any person, infant, adult, whoever, the first that you need to do is to see in the medical administration record, either in paper or electronic, the order for the medication. So you don't know what you are going to give until you check first before going to the client. Okay, you need to check first in the MAR the order of the medication. You don't
D,
give
Professor, D. I'm sorry, I just read really quick.
Okay, so for everybody, the next time when you graduate, you pass the anchor. The first that you do when you arrive to your shift is to check the medical administration records. There, they are going to say for each client which medication need to be given, at which dose, which route, and at which time. And then you start, once you see the medication that need to be given, because the prescriber order is transcribed to the MAR. If you find a doubt here, if you find here something that is not satisfactory to you, then you go to the record, the client's record, to see the specific prescriber order, doctor's order. Okay, well, the doctor's orders are transcribed to the MAR. Generally, pharmacy, the one that transcribe to the MAR, but also the charge nurse can do that. Once you see the medication you need to give, then you go to the site where the medication is stored. Okay, it can be a different method depending where you're working. The most common is going to be a computer with drawers. The most common brand is Pixel. And then you go to the Pixel and you enter here the name of the clients, and then you see the medication that is due. You select the medication you want, and then the drawer will open, and then you retrieve the medication. And now you go and prepare the medication to be given, and then you enter to the room with the MAR, because you need to check 3 times. 3 times you need to check the medication that you are retrieving with the MAR. So the MAR says medication X. When you retrieve the medication here in the computer, you need to see medication X. You're retrieving here medication X. You need to see the label of the medication, medication X. When you prepare the medication, you make the second check. Okay, this is medication X. MAR say medication X. Okay, I can pop out, I can prepare the medication. And then when you enter the room where the client is, you need to enter with the MAR. Generally, it's a computer you have in a little cart, a computer you are carrying, and then you enter. And then even you are going to have double security system where you scan the armband of the client and the barcode of the medication that you retrieve. And then you give the medication, okay? And before giving the medication, you ask for the name of the client, the date of birth, and scan the armband. You position the patient in a position that the facilitate administration, and then you administer the administration specifically depending on what else. But the first that you need to do is to go to the prescription, to go to the origin of the prescription. And the option that mentioned that is the last one, D as in diamond. Okay, so verify the order and the available medication is what you do first. Okay, and then go to the rest, identify the client, position the clients, and then administer medication in the pocket that they describe there, because an infant is a small child. The nurse is receiving the morning shift. What patient should the nurse see first? Client with myocardial infarction 72 hours ago. Client to be discharged in 2 hours. Client with UTI, urinary tract infection, and a dose of levofloxacin IV. Client admitted with asthmatic status and disappears, absent with,
D.
of course.
D,
This,
D.
this is the patient that has the priority. It's a patient that is acutely decompensated with the B of ABC. The next need to be C after you stabilize D. And the next is going to be B, that need to be discharged, need to be prepared, everything. And then the patient had the myocardial infarction 3 days ago, probably is already stable and in rehabilitation and standing medication. Select the position immediately after surgery for ventricular peritoneal shunt placement in a client with hydrocephalus and increased intracranial pressure. So it is a client that had inside his skull has too much liquid in the ventricles, had an hydrocephalus. And for that reason, the doctor had too much liquid inside the brain. So for that reason, the doctor introduced a catheter in the ventricles, and this catheter is living under the skin. Is living under the skin, okay, under the skin, okay, and it's going to descend behind the ear, through the neck, but always under the skin. It's going to be there forever, through the chest and onto the abdomen. In the abdomen, the catheter will enter in the abdominal cavity, and now the liquid is going to be drained through the catheter and spill in the abdominal cavity, where it's going to be absorbed. So the patient, before entering to the OR, is having too much liquid and too much pressure. And then the doctor places the tube and the liquid start draining. And they ask immediately after the surgery, in which position you place the patient, flat, 30, 45, 90. You have the different position here. What do you think about this?
90.
Flat. Flat.
C.
A. A is an apple?
Flat.
Okay, so the answer is flat. The reason for which the client needs to be flat is because you don't want this liquid draining too fast, too much fast to the abdomen, because the patient will develop a hypotension of the liquid in the brain, which is going to produce a horrible headache and many other symptoms. It's the same reason for which when the liquid is extracted in the spine, in the lumbar area, in the lumbar tap, the patient needs to be flat, okay, for a while after the procedure. It's because these procedures, like the lumbar tap or a ventricular peritoneal shunt, that move liquid from the liquid is, and put that in whatever side, is going to produce too low pressure, and it's better to avoid this too low pressure, keeping the patient flat without pillows, you know? So this way the brain can adapt to the lower pressure gradually, without having this severe hypotension that occurs inside the brain when the liquid is extracted violently and drop too much. So the position after ventricular peritoneal shunt is the patient flat, to avoid brisk or violent, okay, shifting of the fluid through the shunt. Which of the following findings needs to be reported after a cytoscopy? Cytoscopy is an endoscopy of the urinary bladder. There are stuff that are expected, stuff that are not expected. So you have pink urine, abdominal rebound tenderness. Rebound tenderness, you need to recognize that as a sign of peritonitis.
Peritonitis. Mm-hmm.
Burning sensation of urinating and frequent urination. So obviously, if somebody has a tube introduced in the urethra, little trauma can occur, so pink colored urine is expected, burning is expected, and frequent urination for the same reason is expected because of irritation. Fever is not expected. Macroscopic bleeding, so bright red blood is not expected. Severe abdominal pain is not expected. And of course, signs of peritonitis, like the rebound tenderness, okay, is not expected. It means that probably in the procedure, the bladder got perforated. So that's why it's very evident that abdominal rebound tenderness need to be reported immediately. What client should the nurse see first when receiving the chief in the medical surgical floor? Which clients is worse? Spinal cord injury, T6, without bowel movement in the last 2 days.
No, it's expected.
Brain tumor, heart rate 94 beats per minute.
No.
Spinal cord injury at the T3 level and has nasal congestion.
Yeah, it should be that one because it's creating like intracranial pressure.
Autonomic dysreflexia.
And the last is hemorrhagic brain attack with headache. So let's see what we can rule out. The brain tumor and the heart rate that is normal is not any problem, so can be easily ruled out. No? The patient that has spinal cord injury, they have as emergency, basically the autonomic dysreflexia. Increased intracranial pressure is not common in a spinal cord injury because a spinal cord injury not necessarily imply head trauma. So the autonomic dysreflexia, which is a hypertensive crisis, would be the concern in a spinal cord injury. And a patient that is already hospitalized, is already diagnosed with a brain hemorrhage, is expected to have headache. So they don't describe anything special in the headache. So brain hemorrhage, everybody knows that produces headache, so it is expected. So obviously the question is about spinal cord injury. And in spinal cord injury, okay, in spinal cord injury, the main topic that is tested is autonomic dysreflexia as a priority. You know? The autonomic dysreflexia, as we says, is a hypertensive crisis that can occur mainly when there is urinary retention, which is the most common, but also cuando hay fecal impaction, or cuando hay bed sores, pressure ulcers, the AC is too cold, etc., etc. So autonomic dysreflexia occurs generally when it is T6 or above the level of injury. So both are possible. The patient that have 2 days without bowel movement could be potentially developing a fecal impaction. So it is a risk factor for autonomic dysreflexia. But then the patient that have the nasal congestion nasal congestion is a manifestation of autonomic dysreflexia. So A is risk of autonomic dysreflexia. C is a symptom of actual present autonomic dysreflexia. So C seems to be the priority. The symptoms of autonomic dysreflexia are headache, hypertension, bradycardia, flushing, nasal congestion. Those are the symptoms of autonomic dysreflexia. So evidently, the one that has more probability of having autonomic dysreflexia, actually, in this moment, is C as in cat, but because autonomic dysreflexia. So I agree with you. C is the answer that I'd choose. Which client should the nurse see first in the psychiatric ward? So psychiatric priority. Bipolar pacing and screaming with anger, schizophrenic having auditory hallucination and fear, client in paroxetine showing rigidity and tachycardia, bulimic locked in restroom for too long after lunch. So now you need to decide of these 4 patients that all are in issue need to be seen.
Yes, and cat.
Yes.
Sí.
What are you thinking?
He's having it.
Definitively, I didn't understand anything. So it's not reflecting.
Sí, I think it's sí.
Sí, I agree, sí. But now I want to know what condition you are thinking.
Extrapyramidal syndrome.
No, because the extrapyramidal syndrome.
Serotonin syndrome?
Serotonin, sí. The extrapyramidal syndromes are not emergencies. Okay, the EPS are not emergencies. So the most acute, the most immediate after a dose of a medication, for example, haloperidol, is the acute dystonia. The dystonia generally is torticollis. You know, torticollis. Tenemos lo que es torticollis. Okay, so it's a patient that have the neck, okay, contracted, or sometimes the tongue protruding. It's very annoying, but it's not life-threatening. And the other is the oculo of eye, oculogyric crisis. Is this the other form of acute dystonia, in which the eyes of the client deviate upward, looking up, okay? Looking up, and cannot look downward, This is the oculogyric crisis. So this is the two most acute forms of EPS, the dystonia, torticollis or protruding of the tongue, oculogyric crisis, okay? But nobody is going to die of this. Nobody is going to die of this. Those patients, if they wait, this is going to pass alone without treatment. But if they give the benztropine is the medication, can be even injected, is the medication that can eliminate the EPH. So if the nurse gives a dose of benztropine to this client with acute dystonia, the acute dystonia disappears. The other EPS that can happen is Parkinsonism. it is more subacute, so appears in hours or days. Parkinsonism. So the patient looks like a Parkinson. So is rigid, is shuffling, is leaning forward. So has this stoop posture gait, is shaking, has tremor. The same, if the medication is discontinued, it going to disappear alone. And if they give benztropine, it also improves a lot. So usually doctors what do is to reduce the dose of the antipsychotic and give benztropine congentin. But nobody is going to die of this. The other EPS that you need to know is called akathisia. Akathisia is a person when receives those medications that are moving all time. So all time moving. Sit down. They sit down, immediately get up, and then start walking. And the leg is sitting, and the leg is shaking the leg. I think that I have akathisia because I like this, okay? And this is akathisia. They don't stop moving. They don't stop moving. And the other that is important, but is very late, appears even months and years after taking the medication. It's called tardive dyskinesia. In this case, the first symptom is in the mouth. The patient starts, having movement in the mouth, involuntary movement in the mouth, like lip smacking, like moving the tongue, twisting the lips. And if it is not recognized at this level, when the patient is having this movement in the lips, in the mouth, then patient start making weird movement with the arms and the legs. Tardive dyskinesia is important because it's not reversible. As I said, all the previous EPS that I mentioned are reversible or improve with benztropine. The tardive dyskinesia is not reversible and does not improve with benztropine. For that reason, it's important to be recognized, and you can have a question about this because the medication need to be discontinued. Now there are new medications. I saw that in the TV, new medication for tardive dyskinesia. A lot of interesting commercials of tardive dyskinesia in the TV. Okay, I love the commercial of medication in TV because I learned a lot, but it is not important. Okay, so those are EPS. The EPS are not going to kill anybody. What can kill lethal, okay? A psych patient taking medications are two conditions. One is called neuroleptic malignant syndrome. Neuroleptic is the family of the medication for cuckoo people, the anti-cuckoo medication, antipsychotic medication. And the other condition that can kill a person is a serotonin syndrome. They are very similar. They have rigidity, they have altered mental status, and they have fever, hyperthermia, hypertension, and tachycardia. But the neuroleptic malignant syndrome is produced by antipsychotic, for example, Haldol, or any other antipsychotic that you have studied. The chlorpromazine or the quetiapine, aripiprazole, risperidone, clozapine, etc. But the serotonin syndrome is not produced by the antipsychotic. It's produced by the antidepressant of the family of the SSRIs, selective serotonin reuptake inhibitor, and fluoxetine paroxetine is an SSRI. If the patient were taking Haldol or any other antipsychotic, the symptoms will be the same. Maybe adhere fever. The fever is also frequently mentioned. But because the patient is taking paroxetine, then they are talking about serotonin syndrome. In 2 words, to simplify, memorize for Nclex that there are 2 conditions in side effects of the medication for crazy people that can be mortal, can be lethal. One is the neuroleptic malignant syndrome that is produced by the neuroleptics, the family of the antipsychotic. And the other is the serotonin syndrome produced by the SSRIs, like paroxetine, fluoxetine, okay, etc. So in this case, the reason for which you should be choosing C is because you suspect serotonin syndrome, which is a potentially lethal condition. Okay, because then they can make a question about serotonin syndrome. And now you know more or less what means. Usually those patients with serotonin syndrome or neuroleptic malignant syndrome have similar symptoms. I repeat, rigidity, fever, both. Altered mental status, they are not normal. Have hypertension and tachycardia. Okay, those are the characteristics in common with that. The other patients are serious, but not as serious as these, because as I said, these 2 conditions are life-threatening, are priority, need to be managed in ICU. Which pediatric client must see the nurse first? Infant with cough and temperature 102, asthma attack with wheezes and forced expiratory volume, the peak flow meter 65%, 5-year-old with epiglottitis and drooling, 6-month-old with RSV and wheezes.
C as in cat?
Of course, because we need to go to ABC. And the one that is A here is the epiglottitis. Okay? The others are B. And B goes after A. So a patient with asthma and this value, okay, is in asthma attack, but is not critically ill. When it is below 50% is when it's become, okay, priority because it's critically ill. And RSV produces bronchiolitis, and the bronchiolitis is characterized by wheezes, is expected. It's not obviously an emergency there in bronchiolitis. So the patient with epiglottitis, inflammation of the epiglottis. And why is drooling? Because if they swallow the saliva, they choke, and epiglottitis is always a priority. It's the A of ABC. Which finding expect the nurse to see in a client with head trauma and Cushing triad? Cellular apply. So you need to think in a severe, late, increased intracranial pressure, because Cushing triad is a late manifestation of increased intracranial pressure. Systolic blood pressure higher than normal. Yes or no? Yes. Tachycardia? No. You expect bradycardia. A hyperventilation, respiratory rate increase? No. You expect respiratory depression. Diastolic blood pressure, which is high? No. The diastolic blood pressure doesn't increase. Widening of the pulse pressure? Yes. Glaucoma scale 14? No. You don't expect a patient practically normal in their level of consciousness. A Cushing triad is a late manifestation. Heart rate toward the bradycardia? Yes. Okay, so those are the way of selecting those findings. Is clear?
Yes.
So remember the Cushing triad is systolic hypertension, not diastolic, systolic, bradycardia and widening of the pulse pressure. But the patient also presents severe altered mental status and presents respiratory problems, respiratory depression. What finding expect the nurse to be seen in a baby with baby shaking syndrome? Horrible. Bulging fontanelle, yes, because the baby shaking syndrome has brain trauma and sometimes brain hemorrhage. So now has increased intracranial pressure, so the fontanelle is going to be bulging. When there is increased intracranial pressure, there is bradycardia. Tachycardia is not expected. Nevertheless, infant has a very peculiar way of crying when they have increased intracranial pressure. It's a very high acute, shrill or cry that is characteristic of the increased intracranial pressure. The retina has hemorrhage because they hold the baby to be shaken through the arms. Usually they have bruised arms. Cigarette burns is not a characteristic of the shaking baby syndrome, because shaking baby syndrome is one thing and cigarette burns is another thing. And overwhelmed parents is very frequent in a baby shaking syndrome. The
Profe, have
baby,
you seen one of those?
say again?
Have you seen one of those baby shaking syndromes?
Yes,
Aye.
is very frequent. Is very frequent. Baby shaking syndrome generally is a baby, that is crying too much. Frequently is a baby with colics, with milk intolerance. And the baby is crying a lot, is crying a lot. So the parents had the baby, okay, needs to work and have nada problems. Everybody has problems. And the parents, okay, change the diaper, make the baby comfortable, etc., etc. But the baby's crying. So after awakening the parents 10, 11 times in the night, maybe when finally the parents sleeping a little, at 5 a.m., the baby start crying again. And then the parents a little confused, upset, overwhelmed, sleepy. Take the baby, okay? Take the baby, and checks the baby, okay? What you want? What you want? I did everything, and you're still crying. Stop crying. Check the baby. When you check the baby, the head of the baby goes back and forth, and the brain that is inside, is going to have cup and counter cup. Is moving in this direction and has a cup, and then moving in this direction and counter cup. So the brain is going to be shaken and is going to have cup and counter cup. Yeah. And of course, this is going to produce brain edema and even brain hemorrhage. But the eyes are going to suffer the same shaking. And hemorrhages in the retina are found. It doesn't mean that the parents are abusive, are ignorant, and are overwhelmed. There is one question in Nclex that says, what do you recommend parents of a child that is crying too much because has colics, whatever, to do when the child is crying during the night? And the answer is allow the baby to cry for a while. Don't take the baby immediately. The cry of the baby awakens you. Don't get up and grab the baby immediately, because there is a risk that in your confusion and your anger, you can shake the baby. So usually the shaken baby syndrome is not seen in the classical abusive, dysfunctional parents, are seen in usual, normal, average parents that have no the characteristic of being abusive. Because I don't know if you ever been awakened, okay, while you're sleeping and you are not you. Immediately you awaken. And when it is in this kind of situation, it can happen. So this is what I can tell you about the shaken baby syndrome. So can be tested as manifestations, and then I describe that in this question. And the other question that I think up, what you can recommend parents to avoid doing that. Sometimes the father, okay, plays with the child a little rough, and you throw the baby up and then you catch the baby. Sometimes the baby laugh. Okay, this play can produce shaken baby syndrome, have been described. With an example of the ethical principle of veracity. The nurse returns to re-evaluate the clients as promised after pain medication was given. The nurse refuses to administer a dose of medication inadequate to the client's weight. The nurse tells the infant the vaccine is going to hurt a little. The nurse asks for the client's reasons to refuse medications. So, which of these do you think is an example of veracity?
C is in catch because
Of
it's not
course,
telling the truth.
Of course. So it's the only situation when you see that the truth is said. Very well. What lab finding in a client receiving IV heparin requires the nurse immediate intervention? APTT 70 seconds, platelets 130,000, INR 1.1, positive D dimer. So you said C as in cat.
Yes.
Okay. Why? Why you are concerned about the INR if they are talking about heparin? Because the
You're right.
the INR has to do with warfarin and with liver. And this is a normal INR. So the patient has a normal INR. Normal INR is around 1, 0.6 to 1.2. So this INR is normal. The normal of a person that is not taking warfarin and has normal liver. The INR is more than 1.2, is more than 1.2 if, one, the client is taking warfarin, two, the client has cirrhosis or liver disease. Okay, cirrhosis. Okay, so so it is a normal INR first. Doesn't need to be prolonged because the patient is not taking warfarin. And being normal, the patient has good liver. So there is no concern with the INR. So this is a normal INR in a person that is not taking warfarin. This is your INR. If you do the your INR, this is the value that you have. Why? Because you are not taking warfarin and you have a normal liver. So no, it's not C. You can rule out C. No idea? What about A?
A.
Okay, when a person receives heparin, should receive a dose necessary to prolong, extend, prolong the time. Times measured in seconds, minutes, hours, days, months, years. Okay, to prolong the time that the blood takes to coagulate from 1.5 to 2.5 times the normal. The heparin is evaluated with a time called PTT, partial thromboplastin time. Yeah? And this time should be prolonged 1.5 to 0.5 times if the patient receives heparin. The normal PTT is around 30 seconds. So if you prolong 30 seconds, 1.5 times, it is 45. And you can see that if you multiply 30 times 1.5, yeah, it is 45 seconds. But if you prolong, extend the normal PTT 2.5 times, 2.5 times, it is going 75 seconds. So this is the range or the limits desired, wanted, looked for when a patient receives heparin. The patient has a PTT in 70. 70 is in between this range. So this PTT is good for a patient receiving heparin. So it is not.
It's platelet, Professor.
So the platelets are low. The platelets are low. And the other is the positive D dimer. Okay. What is a positive D dimer? It means that the patient has a clot. Okay. Is expected in a patient receiving IV heparin, is expected to have positive D dimer and having a clot? Okay, the answer is yes. Because nobody is going to receive heparin unless having a clot. You don't receive heparin. I don't receive heparin. Why we don't receive heparin? IV heparin, because we don't have clots. So why this patient has a positive D dimer test? Because has a clot. Because has a clot is receiving heparin. So it is expected. So yes, are the platelets. Why the platelets in these patients are low? Because as far as I know, platelets are not modified in the therapeutic action of the heparin. Heparin, what does is to prolong the PTT, not to decrease the platelet. Okay, so why platelets are a problem, why these platelets are low, and why these low platelets are the problem number one in this patient, the priority.
Risk for bleeding?
Okay, no, the answer for that, because nobody's going to bleed with 130, is something called heparin-induced thrombocytopenia. So you need to be aware that 1 million people probably in this moment are receiving heparin in America. It's an approximate that I'm going to say. In this moment, this minute, in all the hospitals in the United States, 1 million people are receiving heparin. Known, except, let's see, 2 or 1 of these people, known, is having problem with the platelet. Why? Because heparin does not affect platelet. The medication that can inhibit the platelet function are aspirin, clopidogrel, etc. It's basic pharmacology, guys. Something that has been repeated a lot of many times to you. But 1 or 2 people of these million people receiving heparin are going to develop like an allergy. It's not an allergy, but to make you understand quickly, it's like an allergy. So of 1 million people receiving penicillin, only 1 or 2 make allergy to penicillin. See? Yeah? Okay, the same happens with the heparin. From 1 million of people receiving heparin, 1 or 2 are going to develop a condition called heparin-induced thrombocytopenia, in which a immunological, is autoimmune, triggered by the heparin, but it's autoimmune, immunological phenomenon will start decreasing, destroying the platelet, and the platelets start dropping. But this is not simple stuff. There is more in the heparin-induced thrombocytopenia. In reality, what is happening there is a coagulopathy called disseminated intravascular coagulation. Okay, and the patient is going to have thrombus formations and consume of the platelet. So it is this heparin-induced thrombocytopenia is a very serious condition that requires immediate discontinuation of the heparin. So any patient receiving heparin should have normal platelet. But if one of those many patients that you see are receiving heparin start presenting a drop in the count of platelet, need to be immediately reported to the doctor, because this heparin need to be discontinued. And then other type of anticoagulants will be used, because it's a patient that doesn't tolerate the heparin. It's not exactly a allergy, but it's like the patient were allergic to heparin. So you need to incorporate to your knowledge that heparin, you know what means induced, no? Is produced by heparin's producing thrombocytopenia. Heparin-induced thrombocytopenia is a very, very serious condition that must be detected by the nurse in any client receiving heparin in whom the platelets count start dropping, because people receiving heparin should not have a drop in the count of platelets. So this is the important. A person that has the platelets in 130,000, but because other condition, suppose idiopathic thrombocytopenic purpura, which is an autoimmune disease that lower platelet, they don't have any risk for bleeding important. Why? Because you need to have very low platelets, usually less than 20,000, to have an important bleeding risk. The problem is that this initial early symptom which is the drop in the count of platelet, is the announcement that the patient is going to evolve to a very serious condition called heparin-induced thrombocytopenia. So this is the explanation of this question. Which intervention provides the most accurate information about the infant's hydration status? Measuring the infant's urinary output, accurately measuring intake and output, monitoring serum electrolyte level and osmolarity, weighing the infant daily. It's a classical. What is the answer?
D. In the infant daily.
Yeah. If I have a diaper that weighs, when taking new, dry from the box, that weighs 20 grams. And when I remove the diaper after 3 hours, the diaper is weighing 60 grams. 60 grams. How many milliliters of urine peed this child?
40.
Okay, 40. Remember that 1 gram equal 1 milliliter. Okay, this calculation is very common in Nclex. Okay, so everybody understood? Okay, you can know how much pee is producing a child weighing the diapers, dry and then wet. The difference in grams is the same as milliliters. Okay, a client diagnosed with hypothyroidism is treated with levothyroxine. Which finding could tell the nurse that the treatment is effective? The client can wear a wool sweater in summer. The client is resting on bed more frequent when feels tired. The client has a daily bowel movement. The client has gained 8 pounds of weight. What is a sign of improvement with
CS and CAD.
Sí.
Because they usually have constipation.
Exactly. So
They have a slow metabolism, so that means improving.
Exactly. C as in cat. Okay, so the improvement of the constipation, because the patient is wearing a wool sweater in summer, has cold intolerance, which is a sign of hypothyroidism. If the client is resting a lot, it's because it's still having hypothyroidism. And if the client is still gaining weight, it's still having hypothyroidism. The nurse received a telephone call from a diabetic client who has 1 insulin syringe left for the morning dose, but no insulin syringe for the afternoon dose. It is a type 1 diabetic client that requires insulin. Is traveling, is traveling. And the site where the client is, there are no pharmacies. And has only 1 syringe of insulin left, and will be used tomorrow in the morning dose. The client must inject twice daily, and the client with this type 1 diabetes have no insulin syringe left for the afternoon dose, for the night dose. You're understanding the question, no? Okay. The client is unable of obtaining more syringes until the next day, but stated that he has a tuberculin syringe and a 3 milliliter syringe. What is the best nurse response? You can use the tuberculin syringe the same way as an insulin syringe. You have to withhold the afternoon insulin until obtaining more insulin syringes. You can use the insulin syringe left, recap, and use it for the PM dose. You can use a 3 milliliter syringe as far as you are very careful measuring the insulin. So what do you answer in this question?
I would say C because they cannot. Insulin is a very dangerous medication. So
Exactly.
I
So
mean,
only can be measured with insulin syringes. So if there is need, if there is a need, necessity, the insulin syringe can be reused. Okay, can be reused. So the patient, if it's used by the Nclex, so the patient will wash the hands, clean the skin, avoid touching the needle, inject, and then recap without touching the needle, and then can use again this insulin syringe in the night. So it's the best option there. Any other syringe can be used in replacement of for the measurement of the units of insulin, because as you said, it's a very delicate medication that can only be measured with an insulin syringe. Which intervention is correct when applying restraints to an agitated client? The restraints are tied to the side rails. The client is restrained in flat position. A soft pad is placed between the restraints and the client's skin. The restraints are applied tightly, allowing one finger space between the skin and the restraint.
C.
It says C as in cat.
I would say D. D is in dog.
D as in dog. Okay. Okay. It's one finger or two fingers?
I think it's two fingers.
We studied two fingers, yes. All the books say two fingers, not one finger. So obviously A is a no. You don't tie to the side rails. Obviously B is a no. You don't tie a person in supine position because can aspirate. So it's between C and D. C is saying that, it's a soft pad to prevent the skin breakdown. And D is saying that should be tight enough as only one finger allowed to pass between the skin and the restraint.
Easy, Professor.
But I always remember that reading in the book two fingers, not one finger. So I prefer C in this case. Makes sense? Client with history of coronary artery disease arrived to the ER with chest pain. The nurse is going to administer nitroglycerin sublingual as per protocol, which medication previously taken by the patient contraindicate the use of nitroglycerin, acetylsalicylic acid, warfarin, tadalafil, bupropion.
C is in cat.
Yes.
C.
So it is incompatible, okay? It's going to produce a refractory catastrophic hypotension. All the afil, sildenafil, tadalafil, etc., cannot be combined with nitroglycerin. Term gestation client in active phase of labor. So the active phase is stage 1, and the active phase is when there is between 4 to 7 centimeters of dilation. Is already receiving epidural. When nurse needs to intervene. So what is wrong here? Client resting flat on lateral position. So the bed is flat, but the client is in lateral position.
That's good.
Okay. In lateral position. CNA helping patient to sit on bed border for a while. CNA offering eye chips to the client, and client requested a bedpan to void every hour. So what is wrong here? What do you need intervention?
I would say B because the
I also
patient,
can fall.
the patient is with epidural, hypotension. They usually tend to have hypotension. So.
Hypotension, weakness in the legs, could fall. So I think that this is B. The others are correct. The others are correct. This position is correct. These eye shapes are correct. And P infrequently is correct. Client with pressure also stage 3. If it is a stage 3, until which level of the soft tissue is reaching? Skin, subcutaneous, muscle, bone. Need to study that, guys, okay?
Skin subcutaneous.
Subcutaneous. Subcutaneous. So it's reaching the subcutaneous. Okay, they ask a lot if you know how to give the classification. If there is no skin breakdown, only non-blanching erythema is a stage 1. In stage 1, there is no ulcer. It's only a non-blanching erythema. If the skin is broken, but only part of the skin, the dermis is seen in the bottom as a superficial crater, is a stage 2. If all the skin is gone, there is no skin, and then the ulcer, what you see is the subcutaneous, is stage 3. And if you see the muscle, it's a stage 4. Simple, don't complicate. Don't complicate. Which of the following ways is the most adequate to administer a flu shot for an adult client? Of these 4, what is the correct? Dorsal gluteal intramuscular, shoulder subcutaneous, ventral gluteal intramuscular, abdominal subcutaneous. What do you choose if you have this question?
Ventrogluteal intramuscular.
Everybody agree?
Shoulder subcutaneous.
No.
No.
This is the trap. This is a trap.
Okay.
It's a trap because the flu is intramuscular. The only vaccines that are subcutaneous are the MMR and the varicella. What you know about these 2 vaccines are live virus, yes? So it's easy to remember, you should remember that the live virus vaccines are these 2 and are given subcutaneous. The other vaccines are given intramuscular. Okay? Okay, entonces you need to choose intramuscular. I know that usually, because we are not going to remove our pants, we are not going to lower our pants in CVS or in Publix to get the vaccine. We receive the vaccine in the shoulder, in the deltoid, see? But it's intramuscular, not subcutaneous. You can, if you don't want to be injected in the deltoid, you can request to be injected in the gluteal area, which is a good place for intramuscular. But of course, you need a little privacy. But there are two gluteal areas, okay? The dorsal gluteal and the ventral gluteal. The dorsal gluteal is this area that is here. But for the ventral gluteal, you need to go lateral to the gluteus. So the patient needs to be in lateral position, need to be resting on bed in lateral position. No? And then you find the major trochanter, this prominent here in the hip, and then above the major trochanter, you find there a muscle when the patient, lying in lateral position, and this is the ventral gluteal. So you have the dorsal gluteal, which is here, and this is the ventral gluteal. The dorsal gluteal, the patient is in prone, if face down, boca abajo, face down. And then you find this upper external quadrant of the butt. And the ventral gluteal, you find with the patient resting in lateral position, you find the major trochanter, the prominence of the femur, and then above, okay, above. This is the reference. But the problem of the ¿cómo se llama? Of the dorsal gluteal is that the sciatic nerve is here. The sciatic nerve is here. And there is risk of harming the sciatic nerve with this injection. So Nclex doesn't like the dorsal gluteal, prefer the ventral gluteal. So if you are given, like in this question, to choose dorsal gluteal and ventral gluteal, prefer the ventral gluteal for the reason that I explained. The flu vaccine must be intramuscular. The only two that are intramuscular here are gluteals. So you need to dance with the music that the question is playing. You understand? And the trap is shoulder, because you know that, because it's that, but not subcutaneous, because it's intramuscular. And this vaccine must be given intramuscular to be effective. And that's it. So take care. It's just a question mainly to explore details, to see if you are carefully reading. Where is the tip? The tip, you know what is the tip? Where is the tip of a central venous action device inside the right atrium, superior vena cava, subclavian vein, cephalic vein?
B and boy, superior vena cava.
Exactly. This is where the tip is. Patient convalescent 3 days after abdominal aortic aneurysm repair. When ambulating, the client experienced a tearing sensation in abdomen and tells the nurse, I felt like something gave way in me. The nurse observes a wound dehiscence. What should the nurse do next? Which is the same, what should the nurse do first? It's the same. Notify the physician, assess vital signs and bowel sounds, make client lie down and slightly flex the knees, cover the surgical wound with sterile moist dressing.
C and cat?
Correct. The first to be done is to make the patient rest and flex slightly the legs to decrease the pressure that is separating the borders and protruding the intestine out. After doing that is when you cover the dehiscent with the sterile dressing and moist, and don't make pressure, and prepare the patient to OR. Somebody need to be calling the doctor meanwhile. Guys, I'm going to stop here because I don't have more questions prepared to discuss for today. We went faster than I thought. Any question, any doubt?
Okay, thank you, Professor.
Okay, so see you
Thank
Monday.
you.
Thank you, Profe.
Thank you, Professor.
Be aware that when for ABC reason I need to cancel my review, I canceled that in the, how to call that, in the calendar. Okay, so the warning is in the calendar. Okay, usually Yoan, okay, make a notification, but to be sure, officially I canceled that in the calendar. I said up in your calendar, because you have a calendar in the school, okay, in your email, okay, appears as canceled, like the last day that I had to cancel this. Okay, okay, so God bless you and study a lot and take your Nclex soon.
Thank you, Professor.
Thank you,
Bye.
Professor.
Bye.
Thank you.